My name is Maryanne Crockett. I work at the Centre for Global Public Health at the University of Manitoba, and we're really happy that you've come to this symposium. This is called Program Science, Enhancing Coverage and Equity Through Partnership, and so we're very happy to have a number of our global partners here to describe their approach to using data to address both equity and the global health problems that they face in their own contexts. We're going to be talking today about how we work with our partners in different countries and contexts to try to improve equity and coverage of global health programs. Particularly, our history's been in HIV and MNCH. So the first speaker today is Dr. Jamie Blanchard, and he has been my boss for a number of years now. But he has a lot more important roles in history than that. So he's an epidemiologist and public health specialist who focuses on global health. He received his MD from the University of Manitoba and an MPH and PhD from Johns Hopkins University. He is now the director of the U of M Centre for Global Public Health, and he has a Tier 1 Canada Research Chair in Epidemiology and Global Health. And he focuses his research on how the characteristics of individuals, communities, and large populations contribute to the local and global distribution of health outcomes. So he's been providing leadership for the last 20 years in the design and implementation of large public health programs related to reproductive, maternal, newborn, and child health, HIV, AIDS, and other issues in India, other Asian countries, and Africa. And he's going to talk to us about the concept of program science, which he has sort of coined and developed, and which really is the philosophy of how we work with partners and governments around the world. So thank you, Jamie.
Thank you, Maryanne, and it's a great opportunity to be here to share some of our experiences. And as Maryanne indicated, I'm going to provide just a bit of an overview of some of the concepts, and then colleagues of ours from some of our partnerships globally will talk in more detail about some of the work that they're doing. So I'm going to start with sort of setting the scene with an introduction to the way we think about program science, and a little bit about how our center is working globally, some of the things that we're doing. So it's a very high-level view of what we're doing with a few examples. So the way we've been defining program science is the systematic application of knowledge to improve design, implementation, and evaluation of public health programs. And there's a few key characteristics to program science in the way that we think about it. First, and probably most importantly, research is driven by program goals to achieve health impact and equity. So the objectives of what we do in the science and the research that we do is really oriented around health program goals rather than knowledge generation per se. The science is embedded with programs with sustained engagement over an extended period of time. This is usually not the model that is applied for academic research in the context of global health, which is still largely driven by individual projects that are investigator-driven. So, and the ability to sustain research embedded within a program over time is uncommonly supported by most research funding. Research in program science is integrated into all program stages, from the design of the program and the priority setting, implementation, and also the monitoring and evaluation component. So a key aspect of program science isn't just around optimizing implementation or just focusing on evaluating interventions, but also at the stages of setting priorities at the strategic level. And then, of course, another key characteristic is continuing interaction between researchers and program planners, managers, and implementers. And this relates to the idea of embeddedness as well as a sustained engagement over time. So these are all characteristics that I think are really important when we think about our program science. Part of the motivation, and I think another important construct around program science, particularly in relation to looking at complex interventions to improve health, is moving away from the paradigm of a pipeline that sort of drives from development of an intervention or evidence, and then trying to move that down a pipeline to application, and thinking more about how complex interventions changing the metaphor. And Penny Hawes done some great work in thinking this through around complex interventions in health, where we need to move away from the metaphor of a pipeline that's unidirectional to really thinking about the interaction between parts as part of a complex adaptive system, and deriving science out of that, those complex interactions, and thinking of things along that way, keeping program goals in mind, but then adapting your scientific approaches and your evidence generation as part of that, as part of that complex adaptive system. And Justin Parkhurst at London School came up with a very nice formulation. He was focusing on the HIV programs, but he talked about shifting the paradigm for generating and using evidence. And what he was suggesting is that we needed to move away from this construct of getting research into practice, which assumes that you have clear, reliable evidence with a direct cause-effect relationship, and then just moving that into policy formulation and implementation, and then evaluating the outputs of that, to starting from a position which is much more common, where there's evidence gaps, you have unclear causality, complex interventions, multiple interacting factors. And in that setting, the way that you generate evidence is a very different process. So you have to first begin with some basic development of hypotheses and research questions. You develop some initial interventions that are based on that. You start the process of intervention, but then as you go through it, you embed research through the implementation and operational aspects of the program. You do your process evaluations, do some outcome evaluations, and then you iterate and you strengthen your hypotheses as you go along. So this idea of getting research out of practice rather than getting research into practice is proposed as a better way of using research to optimize programs. So that sort of is the way that we've been thinking about and trying to apply our approach to program science. A little bit about our center at the University of Manitoba. The Centre for Global Public Health has an overarching goal of improving health equity. Our principles are aligned with with the way that we think about program science. So we try to sustain key partnerships over a sustained period of time. We try to focus on community priorities, so try not to bring an investigator-driven approach, which is generally something that is incentivized within academic institutions. And then what we do is we try to then take the general academic core elements of research, education, program delivery, and technical collaboration as part of that engagement. And I'll try to illustrate what I mean by sustained partnerships over time. A research strategy, we don't really have, this is a sort of newly minted. Tees will recognize this because he was helping us wordsmith this recently. But we really try to look at, as a research strategy for our center, to do program science to provide health data and evidence to improve policies and programs in support of universal health coverage of quality health care. Our research focuses on a number of different areas, including MNCH and HIV and other infectious diseases. We really focus again on our research on the implementation of effective quality interventions, working at different levels from policy down to the community level. And we really are trying to orient our work around supporting countries as they work towards achieving their objectives and goals in relation to the Sustainable Development Goals. The way we function is somewhat stereotypical in the sense that in most of our partnerships, in most of our contexts, we have three levels of activity. We generally have a program or field level program implementation component. This is where we develop experience about the issues around implementation, usually at scale. We try to look at things at scale wherever possible. We also, at the level of the program planning and design, we provide analytical and technical support, trying to integrate experience from the implementation elements to think about what implication that has on the program design and management. And then there's a broader translation or dissemination role, which is to take experience from different contexts and translating that into information or knowledge that can be translated and disseminated more broadly. Our global footprint is not completely fixed, but quite fixed in the sense that we focus on some core countries where we have partnerships. Those are represented by the red pentagons here. So we have our major programs are in India, Pakistan, Kenya, Nigeria, and then out of those countries we have a number of other partnerships. But those are the places where we have permanent offices, and we've had sustained engagements over time, usually with national or subnational programs. A few partnership examples. Currently, our biggest project is a technical support unit for the government of Uttar Pradesh for reproductive, maternal, newborn, and child health and nutrition. Our colleague, Dr. Vasan Kumar, will be talking a little bit about one aspect of what we're doing in UP, but it's a very large scale program supported by the Gates Foundation in Uttar Pradesh. We've been supporting this program Science Network for HIV Prevention for a number of years, working with the World Bank and the Gates Foundation. And this has included a number of initiatives. In Kenya, we've managed a couple of technical support units for the government of Kenya. We've had an ongoing program science initiative with the government of Nigeria to optimize the design and implementation of their HIV program there. We've had a long-standing relationship with the government of Pakistan on their national HIV surveillance and translating surveillance information into their programs. And we've got one of our newer engagements is in Ukraine, where we've been working with partners in Ukraine to guide programs for key populations, adolescents and young women there. And Asha, from our partner in Ukraine, is going to be presenting some of that later. And a more recent addition to our portfolio is the Countdown. T. Sperma's joined us a couple of years ago, and he's the global director of the MNCH Countdown. So this is another key partnership that we're weaving into our program. And those of you who know the Countdown, it's really increasingly supporting regions and countries to be able to review their progress in women, children's, and adolescents' health, strengthening the capacity of countries as well as institutions in countries to be able to generate and use data to track and improve progress in those areas. A few examples from our work. This is an example of some of our work in Nigeria. We did a lot of work with the government of Nigeria to do an overall appraisal of the epidemic in Nigeria, resulting in a number of different strategic documents, and we're now supporting the implementation of a number of these initiatives for HIV prevention, working at the national and the state level. I mentioned the technical support unit in Uttar Pradesh in India. Uttar Pradesh is running perhaps the largest single RMNCH program globally. They have a population of over 210 million, with a very large public health system, more than 150,000 community health workers, more than 5 million births annually. So it's a very, very large-scale program. And in that project, we're partnering with the government of UP, and initially focusing on 25 high-priority districts, but in the next phase, we'll be going to all 75 districts and supporting the districts. We've been at the sub-block and block levels, but going forward, we'll be predominantly focusing on district and state level support. And here we're looking across the continuum of care, trying to improve effective coverage of RMNCH programs. And ultimately, the objective is to improve MNCH outcomes. A number of different data sources that we're using for generating progress in UP. Vasan will probably go into a little bit more detail around this, but it involves large-scale community surveys, both implemented by us as well as government surveys. We've done a lot of work on mapping and assessing facilities and quality of care, and really trying to improve the routine monitoring system so that we can track progress, identify gaps, and help with the review mechanisms for the health system performance. Looking forward, our future focus, we've been working with these different partnerships in different countries, and looking forward, what we're going to be trying to do is to use these as innovation hubs. So where we're working with different programs, linking them together, and drawing out some of the innovations in the design, delivery, evaluation of programs, linking them together so that there's a lot more cross-learning between them, and also focusing them on providing guidance to other countries as well as global normative bodies in terms of how they can improve effective coverage, drawing on country lessons and sub-country lessons to do that. And I'm going to stop talking there and let the people who are actually doing the work in the countries take us through the rest of the session. Thanks for your attention.
So our next speaker is Dr. Vasan Kumar. He's a member of the Indian Administration Service, IAS, and so these people manage senior executive leadership positions. He's a medical doctor, and he has a, I think MPP must be Master of Public Policy, a degree from Princeton and an MPH from Johns Hopkins. He has more than 15 years of experience in implementing health programs in different states in India, and currently we're very fortunate to have him work with us in UP again with a population of more than, he's up the figure to 220 million people. So welcome, Vasan.
Thank you, Maryanne. Thank you, James. Jamie has already given a brief background about work in Uttar Pradesh. I'm going to talk only about how to create database decision-making culture and systems within government. We do a lot of work on community, on facilities, and on health systems. In health systems, we have three major branches: the human resource for health, the supply chain system, and database decision-making. Today, I'm going to tell about how we create database decision-making systems and culture within government. So as Jamie has already told, Uttar Pradesh has increased its population from 210 million to 220 million between what Jamie spoke and now. And so we are 1/6 of India's population, which is 1.25 billion, and it's on the northern part of India. We are equivalent to the 5th largest country in the world in terms of population, and we have administratively arranged ourselves in 18 divisions below the state, and we have 75 districts, and we have 820 blocks. And we have more than 100,000 villages. The one characteristic is India is very fast urbanizing, but Uttar Pradesh still is predominantly rural with 78% of the population, rural population. We have more than 5.7 million deliveries, out of which more than 55% happens in public health facilities. We have roughly 30 million deliveries happening in public health facilities in a year. These are the indicators, certain indicators comparing UP with India. As he told, if Uttar Pradesh improves, India improves. There's a lot of catching up to do. There's been a lot of progress within Uttar Pradesh also in the last 5 years. It has been the steepest drop within the Indian states, but still a long way to go in maternal mortality rate or infant mortality rate. I think you all can look at the table. There is a lot of catching up required to do, even comparing UP within India. So this is a government organizational setup, a little bit about, because we always work with government, we don't do parallel programs. We have a health secretariat which is headed by the principal secretary and secretaries, and the directorate is headed by the Director General of Medical Health and Director General of Family Welfare, and it is assisted by other support agencies like Health Mission. There's a national health mission across different states, and you have many other World Bank aided project technical support units which help the secretariat and the directorates. At the field level, you have the divisional level and the district level. The district level, there are two important positions called Chief Medical Officer and Chief Medical Superintendent. The Chief Medical Officer is in charge of all the public health, which is delivered through your frontline workers, sub-centers, the primary health centers, the community health centers. And the Chief Medical Superintendent is in charge of the district level apex hospital at the district. So just as I told, the Chief Medical Officer is primarily responsible for delivering large-scale health services from the frontline worker up to the community health centers, which is roughly the block level. The numbers, as per any norms, are inadequate, but still huge numbers. Like community health centers, you have 850 of them. We have around 3,600 primary health centers and around 1,55,000. I don't know whether lakh, how to tell it in 100,000. Okay, 155,000 frontline workers. As I told, the Department of Medical and Health Family Welfare is supported by National Health Mission. The UP Health System Strengthening Project is a World Bank aided project, and the technical support unit is established by University of Manitoba Centre for Global Public Health, and we have other development partners. As Jamie already told, the technical support unit principle is if you improve availability, quality, and utilization of care across the continuum, we expect improved health outcomes, and we follow an embedded approach. We do not have parallel thing that we do separate from government. Whatever we do, we help government achieve its own goals, and we follow program science approach. As I told, the goals of UPTSU is nowhere different from what the government has said. This is an SDG goal across the, world, and it's like reduce MMR to 70 per 100,000 live births, reduce NMR to 12 per 1,000 live births, and reduce under 5 mortality to at least 25 per 1,000 live births. So we have signed ourselves for the outcome. It's like we work towards achieving these outcomes and not only in the process part of it. As of now, we are working under these 5 major areas: maternal health, neonatal child health, family planning, nutrition, and health system strengthening. Recently, we have been asked also to work on the immunization area. And we use 3 platforms: the community platform, the facilities platform, and health system platform. Today, I'm going to talk only about health systems platform, where we work majorly on improving human resource for health, supply chain, and data systems. In the 75 districts in phase 1 and phase 2, we intensely work in 25 districts, which has a population of 70 million. And out of the 70 million population in 25 districts, we have manpower in 100 blocks, which is covering around 31 million. So it's like lab for us. Whatever evidence we want to generate, the data we want to generate, and really implement and see what changes we can bring about. We work in this 100 block population, and based on the evidence and the success, we then take it to the government and make it sustainable. So similar to the structure of the government, we also have a state level, division level, district level, block level presence. But going forward, we will be moving up the value chain, and we'll be more and more concentrating on district and state level apparatus. So why data? Basically in a resource poor country like India, where to put money, resource allocation becomes important, and you have to generate evidence, really database, to see whether your resource allocation is proper or not. And there are many other reasons why obviously we want to use data, but for us, the main thing is from the government side, are we putting the resource in the right place, and are we kind of using the scarce resources correctly? But what we saw was, when we saw that data availability was an issue, most of the data when we started was paper-based data collection. Key program data elements were not being captured. We also had issues with data quality, inappropriate quality of data. There is lack of standard platforms. And most importantly, data use. There was the database decision-making apparatus was not there. Most of the meetings use data ad hoc basis, so data use was also an issue. So our focus was actually on strengthening availability, accessibility, and quality of government data systems. So what we did was, for data availability, we established a platform, a unified platform called Uttar Pradesh Health Management Information System, which is a single source in which all the data coming from different platforms gets on. And for improving data quality, we created processes like validation committee meeting. We have people who looks at data quality at the division level, and data quality audit as a separate activity that is now started in the government. For data use, program managers, it's very difficult to sell data use unless you synthesize all the data and give it in a way that they want. So we have created something called as dashboard, where we rank all the districts across the state, and based on a composite index of 14 indicators, which I'll be showing. We also enhance data use by actually establishing a divisional level M&E hub. We also make sure that program managers start using your UPHMIS and don't go beyond UPHMIS to use data during meetings. On the sustainability part, we really have to enhance the capacities and functionaries for data use. We find that there is very limited capacities available within government to analyze data also, and also to use data. So UPHMIS, as I told, is an integrated portal. It's integrated data assets from different sources. We have an HRMS, we have the human resource management system, where the entire health workforce has been captured onto a digital platform. We have entire the frontline workers, both put together is around 300,000 people. We have the entire HR data source. We have the supply chain data source in DVDMS, and similarly we have other portals which we have all collected all the data and put it onto one platform called UPHMIS. The average number of transactions are more than 25,000. The number of fields that are captured per month is 22 million. There are 75 reports which are generated, and more than 1,000 system users who put this data every month. So for the data quality part, there is a structured checklist by which we always, audit this data quality, and we have created a platform called as validation committee, in which the output of the structured checklist is discussed, and so you see whether the data is as per the quality required. Now, having said that, it's not a one-time activity. So what we recently did was we had 608 data elements which were there in this data set. We really saw whether these are required or not. We had consultation meeting with the program managers. We finalized the new data elements that are to be there after additions, deletions, everything. We revised. Almost 1/3 of it we thought is not required. 1/3 of it we thought can come from other sources. We need not ask the functionaries to enter because there are databases from which it can flow. It was only required 1/3 needs to be entered. So this created a huge positive thing, because you bring people into the fishing net first, and then only you can kind of tighten it. Otherwise it's very difficult in government to go. And this is a continuous process. It will keep on happening. We also added some new things. We have completed the first 4 steps, and now we'll be doing in the next 2 months the modification in the web portal. So as I told, these are large number of data coming from different geographical regions of Uttar Pradesh. Ultimately, we need to synthesize this information and give it to the program managers, for which we created a UP Health dashboard, which I'll be demonstrating. It's a mobile and web-based dashboard. It has indicators across different health programs like antenatal, delivery, immunization, postnatal period, communicable disease, finance, data quality. So across the different health programs that government do, we have created these indicators and then synthesized that into a composite score also. It's a very easy way. Basically, the approach is that you can identify the districts, and you can go to the blocks, identify the poorly performing blocks using this dashboard in a visual format, and also know what are the reasons why these blocks or these geographical areas are poorly performing. So these are the different indicators, right from antenatal to the delivery care to postnatal, immunization, family planning. We have 14 indicators. As you can see, the last 2 are on data quality, because there is always a perverse incentive to kind of just fudge this data and make sure your district is the number 1 in the whole state. So these are key elements, and what we try to do is we try to form a geographical approach. We try to identify the geographical areas which are not performing well, and try to identify the reasons why it is not there. In the next phase, we are also trying to track these decisions in the dashboard itself using a non-text based. Today also we have a data-based decision tracking system, but someone types it and tries to find whether those agreed decisions have been implemented or not. Instead, we are trying to find out whether even those decisions can be from the database itself without textual base, and then we can see whether those decisions are being followed up. I think we have in the initial phase. In the next few months, we'll be able to do that. See, these are the different screenshots. I'll show the same thing in real. Hope it works. And this has been the usage. Actually the usage was pretty low when we started. We have been able to make now at least 70 out of the 75 districts start using dashboard. There is a lot of support from the highest political authorities about this, because but the flip side to it is you always start punishing districts which are not doing well based on these, without actually supporting them and understanding what are the reasons why those districts are not. The Chief Minister's office this time transferred the last 5 worst performing districts, which we kind of told is not a good thing to do. So everyone starts thinking the system is bad. These are the different areas in which around 500 database decision making has happened in the last 18 months, and these are the different areas. But this is too low. Actually, we need to improve the number of decisions that can happen using this database decision making. As I told, there are challenges and there's a way forward. Challenges is that there's always perverse incentive to fudge data. So we are cautious that when you do this kind of things, and particularly when you're capturing data which is captured on a paper and then you're entering onto the system, there is always a chance that you want to change data. So second is dashboard, as I told, should not be used for punishing, but it should be used for improving cycles, identify reasons why districts are not doing well. And also there is always lack in capacity within government about strategic analysis capacity. That's what TSU generally does, use data for strategic analysis, but the challenge is to create that kind of capacity within the government. Moving forward, what we are now going to do is we are going to collect data at source, basically at 2 platforms. One is the frontline workers, where she is delivering services to the pregnant women and children in terms of immunization, antenatal care. There is already a proposal and agreement with the foundation, Gates Foundation, that we should start collecting data at the source. and also improving capacity building for data analysis within government, and last but not the least, the culture of data use for decision making. So it's pretty tough cultural change within the government. We want to bring in that culture of database decision making within government. Thank you.
So Dr. Hafiz is the Director General for Health for the Government of Pakistan, and we're very privileged to be able to have him here with us today and to work with him. He is a medical doctor with a fellowship in pediatrics, so we're kindred spirits in that way, and he also has a doctorate in public health. He is, in addition to that, he is the Executive Director for Health, the Health Services Academy, and Dean of the Faculty of Medicine at, I may not pronounce this, Quaid-e-Azam University, Islamabad. He's a commissioner with the SDG Commission of the EMR WHO. He's been the chair of the WHO Executive Board and the WHO IHR Committee on Polio in the past. And he's part of a team which led the development of National Health Vision for Pakistan and a number of policy initiatives in the country and region. He was awarded the A.T. Shusha Medal for significant contribution to public health in the region by the WHO in 2018, and he's an excellent host. So we welcome him to speak about Pakistan.
Thank you, Maryanne, for this very generous introduction. I was given 15 minutes. I'll try to finish in 10 minutes, and would try to take you through the process of program science implementation in Pakistan over the last few years, which we had used to develop certain policy level documents, and then focusing on one specific intervention. Focusing on one specific intervention, that how we are actually implementing it. While this is being set up, let me give you a background of Pakistan. Most of you would know, but its population is about 220 million, just equivalent to, we are the 5th largest country. And this was the recent census. We have a devolved setup as far as health is concerned. There are 5+ provinces and regions which are responsible for service delivery, but there are certain specific responsibilities with the federal government and the Federal Health Ministry. And one of them is research and innovations. The Federal Ministry has its implementation responsibilities in the federal capital, which is a mini province of about 2 million population with urban and rural settings. So we are mandated with development of national policies and strategies and directions, and then coordinating with the provincial governments for resources and for implementation, and then monitoring and the rollout of those policies. Whereas in the federal capital, the ministry does itself through its human resource and through its facilities, both in the primary and secondary and tertiary level. So that's the general background of the work which we have been doing. I would take you through the development of the National Health Vision, which was actually the overarching VN document for the next 15 years, which was developed about 2 to 3 years from 2016-17. And based on that VN document, we had national action plans for 5 years, focusing on the priorities which were actually identified in the National Health VN, which links up with the global thinking in health, for example, the SDGs and universal health coverage, and downstream it is linked up with the provincial strategies and the provincial paraphernalia. With this background, I would be specifically talking about how the universal health coverage strategy was unrolled and is in the process of being unrolled. I will talk specifically about using of evidence for national priorities, research for scoping and prioritization for the priorities which were identified, and then implementing the priority. And we would specifically talk about the essential service package, essential health services package. So this we would try to take an example that how we steer our way through the data and the evidence available and the possible research. For the National Health Vision, the evidence for setting strategic priorities included the public opinion. It's all national policies at the end of the day are political documents. But the science in it is through the data sources, which is something like the health information system dashboard, which was just demonstrated. There is a national dashboard from various sources, with its pros and cons. The data quality is again an issue with as was demonstrated. We have national health accounts. We conducted an expert opinion analysis. We have national and provincial health surveys, which are periodic and done at different points in time. Then the burden of disease data and epidemiological trials for Pakistan, and global and regional systematic reviews and meta-analysis. These were all collected together to put in place the national vision for 2016 to 2050, 2016 to 30. The statement, and I'd like to invite you to concentrate on the underlined, the wordings, which the overall national vision is to improve health of all Pakistanis by providing universal access to affordable, quality, essential health services. This was identified as a major goal in our national health vision. So based on this, a national action plan for 5 years was developed, which addressed primarily the primary healthcare and the community settings and service deliveries, as well as the hospitals through the insurance program, and some priority areas like nutrition, polio, communicable diseases, and non-communicable diseases. So these were identified, some top priority actions through this exercise in this National Action Plan, which we are rolling out now, starting from this year. And it coincided with the new government in place in all the provincial as well as the federal area. So the national vision remains the same, but the 5 years action plan and the term of the government is 5 years. So based on that overarching umbrella, the government developed its own national priorities. So talking specifically about the universal health coverage, which we identified as one of the main areas, we developed a strategy that how universal health coverage should be achieved. And we do understand that universal health coverage comprises of financial protection, the coverage of the coverage, and the service or the benefit package. So we'll be talking specifically about the essential service package. We got our cue from Disease Control Priority 3 exercise, which is a global exercise, which was carried out as DCP3, which has identified a costed benefit package, which is quite generic and has to be adopted at national and then at regional level. So we took up that, and Pakistan was termed as the first country to adopt it at national level, the DCP3 priorities, which has 219 interventions in 5 different platforms, starting from community, primary care, secondary and tertiary care, and then the population level. So these 5 platforms for these 219 interventions in 4 sectors, which I'll be coming to in a while. But before that, a research was carried out based on the available data that what are our national burden of disease, which are periodically carried out, what is our available epidemiological studies, and the project data and the dashboard. These were all taken into account. Pakistan has about still about 50% of disease burden in non-communicable diseases, whereas 43% or 45%, around 44% is the communicable disease component. So this was the available data which we had. We wanted to see that out of these 219 interventions, how many are existing in our different tiers across the country, so that we build up on the available infrastructure and the available facilities which we have. So we conducted a study in April 2019, briefly with a review the scope of current essential health services in Pakistan against the DCP3 recommended interventions. And then it was to produce a plan to develop a generic UHC benefit package in the local context. So the key findings were that out of 219 recommended services, 135, that's about 60%, are being currently implemented in the existing primary care and tertiary care and secondary care and community level structures. So about 20% of them were generally available, and 40% were available at limited level. And this was a national exercise which took about 2 to 3 months, and the situation generally varies from province to province. Just giving you a bit more detail, on this column we have the clusters for those 219 interventions. These are in RMNCH, there are 67 recommended interventions, in infectious disease 52, and NCDs and injuries 45. And in the second column, we have the general and partial availability. So out of 67, 50 were partially available in RMNCH, which has been our area of focus in the past years. The mortality figures in maternal child mortality was our major issue. So we can see actually quite a lot of those facilities either partially or fully available. In infectious diseases, again, 60% were available. NCDs and injuries is a relatively new area of emphasis. So the existing facilities were much lesser. If we see the same from a different lens of level of delivery, which are 5 levels, community, primary, first level, tertiary level, and population. So this is the breakdown of all of those. And you would realize that in the hospitals, somewhere, and this happens in most of the developing countries, in tertiary hospitals, in secondary hospitals, the number of available services was much more. Whereas in the primary care and community care, the number of available services was much lesser. And this actually shows that the type of funding which has been happening in the last 20 to 25 years, more in the tertiary care vis-a-vis primary and preventive care. So we need to change that balance of investment as well. Based on this exercise and the priorities which we gathered through a systematic way, this package of 21 services for primary care and a community level has been developed, which is essential package of health service, which is called essential package of health services. This has been derived from DCP3 interventions, but not all of the interventions have been included, which were prioritized and given to us through this exercise research which was carried out. Now, how are we implementing it? The federal government has the mandate to implement it in the Islamabad territory, whereas we are also taking one district each in each of the provinces to unroll it, but it is being, at this point in time, it is being implemented in Islamabad territory at the moment. While it is being implemented, it's a continuous circle of generating new evidence and then using that evidence into the implementation methodologies. We have identified target population. The costing, though DCP3 is costed in a different manner, but that costing has to be indigenized. So we are undergoing that process of costing each essential service. And then economic benefit analysis. Similarly, the training required and the curriculums and the service delivery standards, these are being simultaneously developed. And based on these, the essential services or the packages are upscaled or delivered at an appropriate scale on the 5 services. We are looking at, and we were discussing it yesterday with Jamie and others, that how to track the effectiveness of this package. We need to develop a One Health survey, which not only picks up the facility level, which not only picks up the delivery, but also the impact and the effect on the population, targeted population. So this mechanism would be made part of the implementation process, so that if certain services are taken up in a better manner, those would be improved. Other services which are not that effective because of certain reasons, either they would be improved or taken out of the package. We have developed a UHC index for each intervention district, and baseline would be compared with, again, this would need a regular One Health survey. We have completed mapping of all public and private health facilities. Similarly, the health facilities readiness through SARA tool, a modified SARA tool is being carried out and would be a continuous process, along with certain qualitative studies. So this is all one package of delivery of those prioritized services. Some of other intersectoral interventions also are part of DCP3, which would also be made into this package. As I mentioned earlier, regular monitoring of impact is of utmost importance, and so the measurement is the key to successful implementation. Anything which doesn't get measured doesn't get improved. So we believe in that, and that's we have also requesting TEAS to come to Pakistan to help us in these measurement issues in times to come. Similarly, once this is being rolled out, simultaneous plans for phase 2 scaling up into rest of the country are being developed based on this evidence generated. The EPHS would also have to be adapted for each provincial level, which are slightly different, and this prerogative is with the provinces to add or remove services. And similarly, institutionalization of research agenda at national and provincial level would give a complete picture to this whole the science of implementation, which is based on evidence and research, but is really gelled together into the program delivery systems. That's what exactly Jamie was talking about this morning. So thank you very much for your attention.
Thank you very much, Asad. So our final speaker, before we have a chance to talk as a group and ask some questions, is Dr. Daria Pavlova. She holds a PhD in sociology and heads the Department for Monitoring and Evaluation of Social Projects in the NGO Ukrainian Institute for Social Research after Alexandra Yeremenko. Daria has been actively involved in fundamental and applied studies on family, women, youth, and children, including particularly those at risk for HIV, exploring processes related to young people's integration into society in the context of social and economic transition, and has been involved in design and advocacy of government programs on youth and children, including those living with HIV and AIDS, as well as participating in the national program aimed at overcoming HIV and AIDS in epidemic in Ukraine. And for the past 7 years, she's been a collaborator with us at CGPH at the University of Manitoba. Welcome, Daria.
First of all, thank you for the opportunity to be here and to present the results of our work and our collaboration. I will be talking just about a small portion of the activities that we do in Ukraine, but I thought that it would be very important to talk about our collaboration with University of Manitoba. And we have met Jamie in 2012 when they first came to Zaporizhia and introduced a very interesting strategy and very interesting idea of mapping the key populations. And since then, our collaboration started. So the first project that I will be talking about, and I will not be talking much about the data or results that we have received, but I will be talking mostly about the partnerships and ideas that were developed and advocacy that was done after or during the project, because some of the projects that I will be talking about today are still ongoing. So in the first project, Mapping of Key Populations, we had several partnerships on international level, and technical support we have received from Center for Global Public Health, UNICEF Ukraine, and International Center for Infectious Diseases. Our institute, Ukrainian Institute for Social Research, I will be shortly calling it UISR, was a national coordination and responsible for implementation of the project. And local implementation was done by Spodivania Charity Fund, Youth Friendly Clinics, and 100% Life, which was formerly known as All Ukrainian Network for people living with HIV/AIDS. Just a small overview of study design. I will not be stopping for the sake of time, but we were working mostly with three major groups: female sex workers, young female sex workers, young people who inject drugs, and street-involved youth. So we were targeting respondents and participants of the age 15 to 24. And this project had several types of beneficiaries, direct ones and indirect ones. So direct ones you see in particular our key populations and NGOs and state organizations that were participating in the project. Indirect beneficiaries were UISR and national stakeholders. And by national stakeholders, we relate to Ministry of Education, Ministry of Health, Ministry of Social Policy, Ministry of Youth, Family and Sports, and international and national organizations working with key populations in the area of HIV, STI preventions. So what were the outcomes of this project? First of all, and one of the most important outcomes was the capacity building of all the stakeholders, because we were conducting trainings, we were talking about capacity building, we were talking about advocacy. We tried, and I think we were a bit successful at that. We improved the coordination among the stakeholders, because I will not probably open a secret box for everyone, but coordination sometimes can be a tricky business, and sometimes it does not work the way we have it in our minds. The picture is, the reality when it hits us is a bit different from what is in our heads. We established new partnerships. And one of the most important partnerships that we had, and the new tie that we created, was the cooperation between Youth Friendly Clinic as a state organization, NGO. And funny enough, before our project, they never had even an idea that they can work together. That Youth Friendly Clinic as a state organization that has a capacity and has the ability to provide free medical services to young people, and NGOs that has a potential for finding clients, they never thought that they could work together. So that was the tie that was created. That was the partnership that worked together. And surprisingly enough, it was a successful collaboration and it was a successful cooperation. And Youth Friendly Clinic was surprised that they can work with an NGO, and NGO was surprised that nobody is trying to take their clients away, because they are working together, they're working successfully together, and they are creating better future for young children. So we developed a referral system, successful referral system, when NGOs would bring clients to Youth Friendly Clinic for consulting, for testing, for medical services, providing their own system. And the Youth Friendly Clinic would take their clients and also refer to NGOs for social services, for legal assistance and legal aid. There was a unique client database created for both youth-friendly clinics and NGOs, which helped to connect the dots. This collaboration and this project helped to develop tailored programs for street-involved youth, because before that, and at some point, I have to admit that government did not recognize the problem of street-involved youth, because that is something that governments are not willing, especially local ones, are ready to admit that we do not have street-involved youth. The same thing as when I come from the Soviet background. In Soviet Union, maybe you don't know, but we did not have sex. So it did not exist. So the same thing goes for the street-involved youth. It did not exist, because if you admit something, it means that there is a problem, you need to work with the problem. If there is no problem it is. So we help tailor those programs. At the time when this project was evolving, in Ukraine, you've probably heard, we also had a conflict taking place, which some refer as war, some refer as political conflict, some refer as civil conflict. And we had a number of internally displaced people among young populations, among older populations. So that was another key population that appeared. That was another target group that we started working with. And that's also was important for us at that point. And of course, one of the key moments and one of the key outcomes of this project is that we started engaging clients themselves in development and planning of HIV prevention programs, in STI prevention programs. So we gave them a voice to provide in development of the programs, and we think it's very important. And the last but not the least, we established and coordination council at oblast level. So it's like a province in Canada if we try to draw parallel lines. And that coordination council would be consisting of decision makers and stakeholders to help develop the programs, issue orders that would support certain ideas that were at that level. The second project that University of Manitoba offered us to partner with was estimating female sex workers' early HIV risk and the implication for HIV epidemic control in Ukraine. So we call it shortly transition study. And why we call it, once again, the partnerships are international coordination with Center for Global Public Health in University of Manitoba. Our institute was responsible for national coordination and implementation. National partners included and international partners included Public Health Center of Ministry of Health of Ukraine, Alliance for Public Health, University of Toronto, Canadian Institute for Health Research, Imperial College of London, CDC, Public Health Agency of Canada, and local implementation, because this was specifically in one big city. And by big, I mean Ukraine big, not India big, because now I feel like in the beginning of the day, I knew that was coming from a large European country, but now I feel like a little toddler being proud of our 44 million population in the entire country. But that was a big city in Ukraine, a millionaire city. We have 1 millionaire population in that city. So DEF Group as a research assistant, Virtus as an NGO was our big partner, and Oblast Aid Center, who was providing us with medical workers and medical assistants in testing, because that was a biobehavioral study. Why we called it transitions? Because we were trying to look at different periods of young girls' lives, transition from sexual debut to first sex, transactional sex, from first transactional sex to first self-identified as female sex worker, and from that first identification to the program engagement. And so the main idea was to measure the risk at all these different stages and to see what is the access gap, meaning when girls do not have access to the programs. And once again, this was among young women aged 14 to 24. We had 3 groups. One first group were girls who were practicing casual sex, not identifying themselves as transactional or commercial sex. Second group were the girls that did not identify themselves as commercial sex workers, but we identified themselves as transactional, those that practice transactional sex. And the third group, those that were engaged in formal sex work and identified themselves as female sex workers. So beneficiaries, once again, direct ones, adolescent girls and young women, the Dnipro Oblast Aid Center, Charity for Virtus, and indirect were more at national level, including our institute. So what were the outcomes? First of all, we highlighted the existence of the hidden group of young sexually active women with higher risk of HIV and HCV infections. So we were surprised to find out that girls that practice casual sex are very much sexually active, and they are at higher risk of HIV, and that also helped us to promote the idea of better sexual education in educational institutions. Study findings also provided us ground to reconsider the resource allocations, the organization of prevention and treatment, to understand how existing strategies cover possible hidden groups with high risk and level of HIV and HCV. One of the problems that we encountered while working on that project is that we found out that NGOs feel very comfortable working with existing clients and being, well, let me say, a bit lazy in recruiting new clients, because it's more convenient, it's more comfortable to work with already people that know you, they come to you. But we have started talking about that we need to engage new clients. And Ukraine is a country where peer-to-peer does not really work. So when we come to India, we come to Kenya, they have great peer-to-peer strategy. They have great collaboration of, even if we talk sex workers working with other sex workers. In Ukraine, this doesn't work, unfortunately. So, and there is a big burden on NGOs to find new clients. And NGOs say that we lack staff, we cannot do that. So now we are at lobbying and we're talking at different levels that NGOs should be focusing on new clients that rather than old ones, because old ones, they know the level, they know their risks, they know how to behave, they know how to respond to potential risk. However, the younger ones and those ones that do not have access to programs, they unfortunately are at higher risk. And another outcome is that we advocate for the change of program monitoring indicators for HIV service NGOs. So we offered to include the relative share of new clients and the relative share of young key populations representative. And I'm proud to say that the first indicator, inclusion of relative share of new clients, is now part of the agreement between Charity Fund Alliance for Public Health, who provides money to beneficiaries and is a beneficiary of Global Fund. So now this indicator is already in the program, and we are happy that we made that change a little bit. So implications, what we think should be done further in this area. So primary prevention activities should be strengthened. We have to talk about targeted educational campaigns on HIV and HCV prevention. We need to talk about women that engage in transactional sex, because study showed that this is a very hidden group, a group at risk that we never talked about. We never even thought about those women, because we always had female sex workers and we have just casual sex, and we never thought that there is something else to that. So we need to talk about that. We need to talk about the strengthening of testing strategies and campaigns for young people, especially women. We need to talk more, and we do talk more about public advertising for condom use. The data of this project it also added a lot to the Say No to Violence campaign and anti-bullying campaign. We also kind of embroidered that. Strategy for sexual education and for adolescents in Ukraine is a big issue, because the Ministry of Education sometimes is not willing to open eyes to the problem that we may be facing in the future. Biobehavioral studies, and we are talking about it together with Center for Global Public Health, should be focused on risk networks and risk environments. Biobehavioral studies, unfortunately, focus on a bit different things, but we need to look at the networks. We need to look at those intersections. And given the high mobility among women in Ukraine that are involved in sex work, a regular mapping should be a routine strategy for NGOs. And NGOs now have the capacity for that, because we have trained them. I have personally conducted several trainings on national level on the mapping strategies. That's something that, on the one hand, is very expensive, but if you do the full-scale mapping. But on the other hand, it helps to save a lot of money, because you know your spots, you know where to find the client, and you know how to work with those clients. And of course, we need to evaluate the quality of programs at educational institutions and to increase their efficiency. And with the last but not the least, we need to reduce the duration of the access gap period, because now it's more than a year and a half of girls that self-identify themselves as female sex workers having access to the programs. And once again, focus on new clients. The third project, it's still ongoing project, and the idea of it appeared at the final stage of the previous one, the impact of the consequences of the conflict in the east of the country on dynamics of sex works and HIV, STI, HCV epidemics in Ukraine. We call it shortly dynamic study so that it shows the dynamics of what's going on. So partnerships are basically the same. We are being very constant in people and organizations that we're at. We just have a little bit more at local implementation, because Charity Fund Virtus, which was our main collaborator in transitions period, they were not as willing to cooperate in the second project, so we had to find other projects and other programs locally to help us implement the study. So that was Road to Life, and that was at Dnipro Center for Social Research. Study design, once again, I will not really talk about it, but our study participants were female sex workers and clients. The main inclusion criteria were that they have to, for female sex workers, they have to self-identify themselves as female sex workers. They should be of age at least 14 years, and they should be soliciting clients at the selected spots. As you can imagine or guess, we also conducted mapping for this study, and they should be engaged in commercial sex for at least 3 months. And the idea of taking 3 months was on purpose, because usually we take more than 3 months. It's usually 6 months or 12 months. But because it's a conflict-connected project, we decided to have it at least 3 months to see the mobility, to see how conflict really influencing the engagement in commercial sex. And for clients, inclusion criteria was more simple. They needed to use services of female sex workers at selected hotspot, and to be of age 18 years plus. Beneficiaries of the project and outcomes. As this study is still ongoing and it will be done in 2021, we cannot say what are the major outcomes, because we're still expecting them. But we already know that we are opening the issues, and we're talking about the prevalence among sex workers and their clients, because clients are usually, according to Ukrainian protocol, they're not considered to be a key population, but we need to understand that they are a key populations by definition. The qualitative component helped to understand the influence of the conflict, meaning that there is an increase in aggressive client behavior, gender-related violence, engagement of women into sex work due to economic reasons. We have used the data from this study also to implement no violence campaign. At this point, we are actively involved in the events to increase low HIV awareness, especially among clients of female sex workers, and to decrease risky sexual practices, and in particular, condom-less sex preferences, both among female sex workers that are not clients of any NGOs, and among clients of female sex workers. As the project was developing, and female sex workers were mentioning that a lot of their clients are basically military men. And unfortunately, military men are underrepresented in our biobehavioral studies. And since the beginning of the conflict, and because of the deployment, because of the mobilization, and according to the data that we have received from the Ministry of Defense, the HIV prevalence among military since 2014 increased 6-fold. So this means that there is a serious problem, and unfortunately, Ministry of Defense does not have a capacity to check the real situation. So they have approached us in University of Manitoba to develop a partnership for implementing biobehavioral research, national biobehavioral study among military personnel. because at this point, the epidemiological data is absent and there is no way to understand what is really happening. And the hypothesis is that conflict is really influencing both risky behaviors, and it's influencing the approach that should be done in the area of HIV, HCV, and STI preventions. And at this point, a new partnership has been established between Ukrainian National HIV Laboratory of Public Health Center of Ministry of Health of Ukraine and the National HIV and Laboratory J.C. Wilt Infectious Diseases Research Center in Winnipeg, Canada, which, personal note, is total future among laboratories. So thank you. I tried to be fast.